So, first of all, should we treat all the LM diseases? Yes or no? If it is yes, then when? So, guidelines has mentioned that they have mentioned the syntax score. According to that, we do the PCI or LM, treat the LM disease. So, IVUS is to an indication for LM. So, it's a story of LM complication. So, first case, a patient, gentleman, 55 years, came with the chest pain on exhaustion. He had history of non-STMI 1 month back. He was diabetic, hypertensive, and echo was normal, and the CG showed there is a distal LM 30 to 40% stenosis with plaque extending to LAD, and ostial L6 was 90 to 99%. So we did the syntax score, and we started the PCI using the IVUS. So IVUS pulled back from LAD and also LAD to LM and also L6 to LM. So the LM distal part was significant, that MLA was 4.3, LM distal. LAD osteo was, MLA was 5.5 and L6 was 1.8 or 9. So we plan to do stent deployed from LM to LCX. So after deploying, you can see that there is a haziness of the osteoproximal LAD. So we did the post-dilatation and port, then finally recross and KBI done. So what to do next? We again, I was pulled back to LAD. It showed that the MLA has been gone down to 2.9. So we deployed a stent, LAD, then final kiss. Then after that, while disengaged guide, and we had a shot, and it showed that there is something wrong with the LM. So we see on the stent boost, and we can see that the stent, proximal part of the stent is deformed. So we tried with the crossing the balloon, but it was unable to cross with 2.5. Then we managed with sequential balloon inflation from 1.5, 2.5. Then luckily we could cross 4.5 and do the port, and this is the final result. Another case, it was done. So when there was a simulation in the medial LAD, but during stenting, during the WAR negotiation, so there was resistant, and then we can see that first shot gave that spiral dissection of LM to LAD. So we negotiate another floppy wear and do the parallel wear technique, and then we were parked into distal LAD and stented from distal, mid, and ostial LM. So this is the one we didn't have IVUS at hand that time. Another case. So the LAD was, so there was a significant stenosis from osteoproximal LAD. So whenever we park both the LAD and LCX, it was ostial LAD. So when we pre-dilated done into 10 millimeter semi-compliant balloon, and there was dissection after that, we can see in the LM. So we deployed 3.5 28 millimeter DES LM to proximal LAD. After that, with a shot, we could see that it extends to the L6 as well. So what done? L6 was stented after recrossing, and this is the final scening. So after that, KBI done, and this is the final stemming. So after that, we took the IVUS. It showed a good apposition of the stent. So there are law that is 4S for the management of complications. So 4S's are stable, smart, swift, and stem. This is the classification of dissection Those are the causes of dissection. But how you can identify the dissections? Appear a filling defect in the coronary lumen or persistence of contrast or lumen-intimal tear outside the coronary lumen. So there may be subtotal occlusion or total occlusion. Patient may complain of severe distress. ST segment elevation might happen, but patient might be asymptomatic. So stenting dissected vessel is not the same as the stenting of non-dissected vessels. So higher rates of complications are there. A propagation of intraluminal hematoma and later stent malapposition due to hematoma reabsorption. So we should be less aggressive and no predilatation. Do not oversize the stent and consider IVUS to help with sizing. And use longer stent and extend when beyond either of the end of dissection, and use the distal stent first, and we can block the hematoma propagation. After that, we can use the proximal stent apposition. So we should be less aggressive and no post-dilatation. Preventive is better than cure. So do not inject when the damped pressure. The guide wear should be coaxial and the wearing should be gentle. And for lesion preparation, avoid oversizing balloon and high inflation pressure. Prepare for heavily calcified and tortuous lesion. Prepare the calcified lesions. So take home message. So meticulous catheter engagement, that is avoid roofing of the catheters. Do not inject when the pressure is damped. Coronary dissection, that is minimize contrast injection and disengage the catheter and non-selective shots. Wearing dissected vessel for ostial dissection, use the penetrating guides like gel, you can use the parallel wear technique or straw technique or CTO technique. Stenting dissected vessels, be careful. Less aggressive pre-dilatation and post-dilatation. Consider pinning in dissection with preemptive proximal and distal stenting. Longer stents do not oversize. So thank you all.
Thank you.